Hi everyone, welcome to Module 2. This week we are essentially going to cover what we covered last week again to make sure that you really understand these concepts: rates, ratios, proportion, incidence, prevalence, and also standardization. And then I'm going to introduce to you some of the most famous epidemiologic studies that we'll probably refer to repeatedly throughout the semester. This is really the one time where I'm going to spend quite a lot of time reviewing a concept that we've already covered, because this information is so foundational. I want to make sure you understand it before we go on. So based on the discussion board from this past week, there were a couple of common areas of confusion. First was the difference between incidence, density, and cumulative incidence, and so we're going to really highlight that. And then direct versus indirect standardization, when do you use one versus the other, and so forth. So that's what I'm going to talk about first, try to clarify some of these issues for you all before we go on to anything new. So just to further clarify the incidence versus prevalence, I don't think too many people had a question about incidence versus prevalence, and yet I think some of the confusion regarding incidence density versus cumulative incidence actually stems from this question. So I want you to think of incidence as an indicator of risk. Remember, incidence is new cases, so risk is basically, do I have a chance of getting this disease? So could I be a new case? So think of incidence as risk. Prevalence, on the other hand, simply tells us how many people have the disease. So it can indicate high risk, but it's not safe to assume that high prevalence equals high risk. Remember the example from last week was coronary heart disease in Birmingham. Maybe the prevalence of coronary heart disease in Birmingham is high because people travel to Birmingham to be treated because there are good doctors here, for instance. Prevalence does not necessarily indicate risk, but incidence does. Okay, so now, how do we know when to use cumulative incidence versus incidence density? Remember that with cumulative incidence, the denominator is changing. So if you have the flu, once you get the flu within that season, you are immune. People do not get the flu twice in one season, the same strand of flu. And the example of hand, foot, and mouth in the preschool that we had from last week, it's the same thing. Any viral disease you don't acquire again. So once you've got it, you're not going to get it again. So that's why those individuals are removed from the denominator. If it's a disease where you can acquire it again, then we wouldn't want to move people from the denominator, like an ear infection caused by a bacteria. You could get that same ear infection over and over and over again. And so in that case, somebody who acquires the disease or the condition, they would still be at risk, so they would not be removed from the denominator. In terms of chronic disease, the reason that we remove people from the denominator once they have the disease is because they're no longer at risk for it. They don't have a chance to develop it if they already have it. So say you have 100 people and you want to know who's at risk for colon cancer. Well, if 3 people get colon cancer out of those 100, those 3 are no longer at risk because they have it already. So only 97 are at risk now. So the denominator would need to be adjusted to reflect the 3 people who now have colon cancer. Cumulative incidence is very commonly used in physical activity studies, so we're going to talk about a lot of studies this semester that use cumulative incidence. They may not even call it that, but that's what it is. This is because these are long-term studies, and it's very hard to calculate exposure time, which leads me to incidence density. Incidence density and cumulative incidence, either one can be used, typically, if you have exposure time. Incidence density is preferred, it's better, to use incidence density because it accounts for not only the number of people at risk, but also the amount of time that they were exposed. So it's a more precise estimate of risk. It's really a better estimate of risk. But you can't always calculate incidence density because you don't always know the exposure time. Someone wrote on the discussion board, "I don't understand how you could know exposure time for flu." Well, you're absolutely right. You couldn't. And in that case, it would be very difficult, if not impossible, to calculate incidence density. So you would do cumulative incidence instead. So incidence density is easier to calculate with chronic conditions. And typically it's adjusted for things like age or years of life. So somebody, say if we go back to colon cancer, someone who's 60 is more likely to have colon cancer than someone who's 30 simply because they've been alive longer. And those types of diseases develop over time. So you would want to adjust for age or years of life exposed in that situation. In maybe a factory setting, for instance, where there's an exposure to some sort of chemical, you would want to know how long the different individuals in the study had been employed there. Someone who's been employed in a factory where they're exposed to, say, asbestos for 1 year has a very different risk than someone who's been employed at that same facility for 30 years. So in that case, you would adjust for the years of exposure, the years employed there. So once again, incidence density and cumulative incidence, they both indicate risk. If there's a scenario where you can account for exposure time, you should do that. But if you can't, you calculate cumulative incidence. If you go back to the previous lecture, there was an example about breast cancer risk in 2 different studies, Nurses' Health Study and NHANES. And I showed you how cumulative incidence could be very different. One of the studies, there was about a 3 times higher risk of breast cancer when they calculated the cumulative incidence. However, when they accounted for follow-up time, the number of years they watched these people to see if they developed breast cancer, once they accounted for that, the risk of breast cancer was exactly identical in the 2 studies. So the point of that was, it's really important to take into account exposure time if you possibly can. It can be pretty misleading to use cumulative incidence sometimes. I want to just briefly make another note about incidence density. I think this is confusing a few people as well. Incidence density can be used to describe diseases that are chronic. I know that I said at one point that incidence is for acute conditions, but while prevalence is for chronic. But incidence density is a little different, and it can be used to describe diseases that are chronic. So I apologize if that was confusing to you. The example here, cardiovascular disease, takes a lot of years to develop, but you may want to study how many people develop cardiovascular disease, how many new cases are diagnosed. Say people who've been physically active for 30 years versus 3 years, just as a for instance. In that case, it would be appropriate to calculate incidence density. Just because it has incidence in the name doesn't mean it can never study a chronic disease. Okay, so I want to give you an example of a study and show you how they calculate incidence. This is probably my favorite epidemiologic study. It's very old, or relatively old. It was published in 1953, and this really is the first physical activity epidemiology study, at least that I am aware of. So again, published in 53, so it's now, old, 60 plus years old. And what this study did, they looked at the London transport system, buses and trains in London, England, during the 1950s, actually really before that, because they studied people over many years. So really it was in the 20s, 30s, and so on that they actually asked people about. So what they did is they had people, men, they were all men, who worked for the London transport system as either drivers or conductors. Drivers drove buses, trains. Conductors took tickets, walked around, interacted with the passengers, and did more standing and walking. The idea here was to determine if physical activity level in your job was associated with your risk of death, mortality. So this is a pretty cool, creative study. It's pretty simple, and yet it was very important in helping to establish the role of physical activity in mortality. Okay, so this, I know it can be a little bit overwhelming, but we'll walk through it slowly. This is one of the tables from the paper. You're looking at the top here, all of this information is from the drivers. All this information is on the bottom is from the conductors. So drivers are more sedentary, conductors are more active, assumably. And if you look here, it's the average annual rates per 1,000. So this is broken down by age. So this is age 35 to 44, 45 to 54, 55 to 64. Presumably your risk of dying. And they also were looking at cardiovascular disease. So they looked at angina, that's chest pain associated with a lack of oxygen. They looked at coronary occlusion, myocardial infarction, that's a fancy way of saying a heart attack. They looked at immediate mortality from the heart attack. Those are people who died from the heart attack within the first 3 days. And then here, in the last columns, total incidence. So hopefully you recognize that word. Total incidence of some adverse event. Angina, a heart attack, and or dying of that heart attack. So within the 35 to 44-year-old drivers, there were 8 cases in the time period that they looked at. What they did is they asked people to be in the study and then followed them over the years. Don't worry about how these rates were calculated. That's not necessary for you to understand at this point. You don't need to be able to do that math right now. But the per 1,000 PA is a way of accounting for exposure time. So these are the number of years that the drivers worked for the London Transport. So they're accounting for exposure time. So that means what you see here in this column highlighted in green is incidence density, not cumulative incidence. They're accounting for the amount of time that people were exposed. Another way you can tell this is man years observed. So that's the number of years that these men worked for, their age times the number of years they worked for the London Transport. So what the results basically of this study showed that the younger people, the 35 to 44-year-olds, their rate was 0.7, and then the next age group 2.5, 6.5. So that's not surprising. Older drivers were more at risk of having an adverse event. And the conductors, there were 0 cases of adverse events in the conductors in the young group. And then the rates here, 2.0 and 5.0. So you can see essentially that the rates were a little bit lower in the conductors compared to the drivers, which is, the authors think, related to physical activity. Next, let's talk about standardization. So I pulled this question from someone's discussion post because I thought it was straightforward and a good question to answer. So the question was, when is it better to use standardization over crude rates? And when you do use standardization, how do you know which type of standardization to pick, direct or indirect? Okay, so to answer the first part of that question, you use standardization whenever you're comparing two unlike groups. The example last week was mortality in Florida versus mortality in, let's just say, California, because California has a younger population than does Florida. People like to retire in Florida. So the average age in Florida is higher. Therefore, it's not fair to compare mortality in California to Florida. You would expect Florida's mortality rate to be higher simply because people are older. Maybe you want to know, is healthcare better in California versus Florida? But you can't really answer that question easily without standardization because of the age differences. Another example is birth weight of babies born to older versus younger moms. Maybe you want to know, do older moms have bigger babies? Well, that seems like a straightforward question, except that older moms are more likely to have had more children, and babies tend to get bigger as women have more children. So you need to control for what's called parity. That's the number of live births, the number of babies that a woman has had. So those are instances where you would want to standardize based on age in the first example and based on parity in the second example. So let's stick with that birth weight example. Okay, how do I know which type of standardization to use? It is dependent on the type of data that you have. So if I'm going to control for parity, or the number of previous live births, say that I know I have the data, the birth weights of babies born to women broken down by their age, but not by parity. Which type of standardization would I use? This is where, if we were in class, I'd make you raise your hand and tell me which you thought it was. But since this is online, you can take your moment to think through. You'd use indirect standardization. The reason is that you have to have the stratum specific rates for the variable that you're interested in. So you're interested in parity, or the variable that you want to standardize by, which is parity in this case. But you don't know birth weight by parity. You don't know all of the women who have had 3 babies, this is their birth weight. All of the women who have had 2 babies, this is their average birth weight, and so forth. If you had that information, you could do direct standardization. But if you don't, you have to use indirect. I want to go back now. This is the exact same table that you saw before with the London Transport, but now I want to show you how they standardized this. Okay, look at this column that I've highlighted in green. This is the incidence, really it's a rate, of coronary occlusion. That's a blockage in a coronary artery. Myocardial infarction is a heart attack. So how many had heart attacks? That's really what you see here. Specifically right here, you see a standardized rate. Again, I'm not concerned at this point that you know how exactly to calculate these numbers, but I want you to be able to interpret them. If the standardized rate is 1.5, that means that the rate of myocardial infarction, heart attack, is 1.5 per 1,000 man-years observed. Remember that we talked about that? Really what's important is that you compare it to this number, 0.8. Okay, the reason we have to do a standardization is because there are people of different ages in the study. 35-year-olds have a different risk of heart attack than do 64-year-olds. And so this is a standardization based on age. Same thing here. So comparing this number to this number, you see that the drivers have almost twice as high a risk, remember incidence is risk, of myocardial infarction than do the conductors. So the people who sit all day are at higher risk than are the people who are more active. And then very similarly with mortality from the heart attack, the standardized rate, 0.9, is more than twice as high as the 0.4 rate for the conductors. Okay, now I'm going to go through a few practice questions that I hope will further clarify this material for you. So practice question number 1, calculate the proportion of men in the NHANES follow-up study who are diabetic. There were a total of 3,340 men in the study, and 189 of them were diabetic. Answer as a percentage. Okay, so this is a really straightforward question. The numerator would be the number who were diabetic, 189. The denominator is the total number of men, which they tell us is 3,340. And so you simply divide 189 by 3,340, and then multiply by 100 to get that in a percentage, and the answer is 5.66%. Practice question number 2. Of the disease frequency measures we've discussed, which are prevalence, cumulative incidence, and incidence density, blank is the most accurate measure when determining disease occurrence in a population. Yet, in physical activity epidemiology, blank is the more often used measure. So which of these is the most accurate in estimating disease occurrence? The answer is incidence density. It is more accurate than cumulative incidence because it accounts for exposure, as we've talked about. But in physical activity epi, cumulative incidence is most often used because it's very hard to estimate exposure time for studies that go on a long time. A lot of these physical activity studies, think about it, you ask people, have you been physically active for your whole life? Yes or no? How much activity do you do? And then they follow those people for years and years and years. And so it's basically impossible to calculate exposure in those instances. So studies that go on for a long time, it's really hard to calculate exposure, and therefore cumulative incidence tends to be used. Practice question number 3 is why in physical activity epidemiology is cumulative incidence used more frequently when it's not the most accurate? And I basically just said this, but physical activity epi studies tend to be large population studies, and it's very difficult to use an incidence density because you have to follow people up until a specific time period, until either they develop the disease that you're interested in, that they become a case, that's what that means, or they're lost to follow-up, meaning they stop participating in the study for whatever reason, or they die. So you would have to know all of those things if you wanted to calculate incidence density, because you would have to know exactly how long the people were exposed to physical activity. So cumulative incidence is more feasible because we just assume that everybody stayed in the study the whole time. So number 4, in a survey of 1,150 women who gave birth in Maine in 2000, a total of 468 reported taking a multivitamin at least 4 times a week during the month before becoming pregnant. Calculate the prevalence of frequent multivitamin use in this group. So again, another prevalence calculation. So the numerator would be 468. The denominator would be the number of women in the study, which was 1,150. Simple calculation, 468 divided by 1,150, multiply by 100 to get that answer into a percentage, and you get 40.7%. All right, practice question number 5. I apologize, this one's a little wordy. An investigation that was started on January 1 identified a population of 1,000 individuals, among whom 10 were existing cases. On March 1st, 4 new cases were found. On May 1st, 4 more cases were reported. On June 1st, 10 healthy participants moved away and were lost to follow-up. Among the total of 8 new cases, there were 6 who died from the disease on August 1st. The study ended on December 31st. Assume that once a person got the disease, they have had it for the duration of the study, and assume that all remaining participants stayed healthy and were not lost to follow-up. So the first question is, what was the prevalence of the disease on January 1st? Okay, this is actually really easy. It's all in the first sentence. January 1, there was a population of 1,000, 10 cases. So 10 divided by 1,000 is 1%. So, first you have 1,000, 10 cases. Then 4 new cases, then 4 more new cases. So 10 plus 4 plus 4 is where the 18 comes from. But the denominator is not 1,000 because on June 1st, 10 participants moved away. So 1,000 minus 10 is 990. 18 over 990 is approximately 2%. Okay. Question number 7 is, what was the cumulative incidence over the entire year? The answer here is 8 over 990. The reason is cumulative incidence is the number of new cases. So we don't calculate or include the first 10 because those were already existing cases. So 8. And then the denominator is the number of the number of participants at the end of the year. So we lost 10. So 8 over 1,000 minus 10 is 0.8%. And that says exactly what I just said, except that assume that everyone completed the study. You have to make that assumption because it doesn't say otherwise. Okay, so I hope that so far you have understood the material a little bit better. Also, please remember that you have a textbook and its purpose is to help you understand this material better. It's actually a pretty straightforward, easy to understand textbook. It's very good, and I picked it for that reason, so I hope it will be a help to you. Please refer to it frequently. All of the material comes from the textbook. I'm not covering all of the material in the textbook, but it's all there for you to see more information. Next, I want to talk about some famous epidemiologic studies that some of these you've actually already seen referenced, but you will definitely see all of these this semester. So, some large epidemiologic studies where they study a large number of people over a long period of time. These are very frequently used to describe the prevalence or incidence of common conditions and diseases. So often you'll hear something like maybe on the news, they spout off these statistics. 10,000 people in the United States have this condition, or 1 in 100,000 people develops this rare genetic disease. Well, how do they know those things? It's from studies like this that have hundreds of thousands of people in them, and they assess prevalence and incidence of common or not so common conditions and diseases. This is also the type of data that's used to calculate mortality rates. So how do we know 5-year survival for stage 3 breast cancer versus stage 2. Well, it's from these types of studies where they've watched what happens to people who are diagnosed with different diseases. So the first example or study I want to introduce to you is called the Framingham Heart Study. And this is a very famous study, really cool. What they did is they decided to study everyone within this small town outside of Boston. Happens to be called Framingham, Massachusetts. This began in 1948. They wanted to study risk factors for heart disease. So you and I, we know many of the most common risk factors for heart disease. We take it for granted that we know that cigarette smoking and high cholesterol and all of these things are related to heart disease. But really, they didn't know that until the 50s and 60s. And the evidence has become more and more clear over the years. So don't take it for granted, some of these things that we know. It seems so obvious, and yet all this information had to come from somewhere. So what they did is they asked people in Framingham to be a part of this study. What they do is they give physical exams every 2 years. And they also collect information via surveys. And so now there's also a group of adult offspring of the original participants. So the people who were enrolled in the late 40s, early 50s, they now have adult children who are being enrolled again. So now we can study some of the familial effects of diet, physical activity, all of the things that we know are associated with heart disease. And so the Framingham study really helped to identify smoking, cholesterol, high blood pressure, all as risk factors for heart disease. It was not well established that those things were associated or caused heart disease before the Framingham study. And then it also helped to show that physical activity lowers risk of heart disease. And so this is a very helpful study in establishing the relationship between physical activity, mortality, cardiovascular disease, and are people dying and from what causes, and is there a relationship between physical activity and cause of death? The Nurses' Health Study. You've seen this referenced a couple of times already. This study obviously assesses the health of nurses. Unlike the Harvard Alumni Study, this is all females. Yes, I know that males can be nurses. However, the vast majority of nurses are females, and so that was especially true when the study began in 1976. Over 280,000 female nurses from 3 different generations have been in this study. The picture that you see on the right-hand side of the slide is the recruitment flyer. They are currently recruiting for Nurses Health Study 3, so this is really the 3rd generation study. They're looking for 100,000 nurses and nursing students. So you could actually still be a part of this study today, which is really cool. And according to the study's website, their goal is to identify risk factors for major chronic diseases in women. So what they do is they ask women to enroll. They ask all kinds of questions about diet, physical activity, their work, and so on and so forth. And they follow them over years to see, do they develop certain diseases, what do they die of, at what age do they die, and so on and so forth. The next study that I want to talk about is called NHANES, the National Health and Examination Survey. And this is still ongoing. It is overseen by the Centers for Disease Control, so it's publicly funded. The government pays for this study, and it's designed to assess the health and nutritional status of adults and children in the United States. That's according to the study website. It began in the 1960s, but it became a continuous program, something they do every single year. That started in 1999. This study is really unique because they do an interview and physical exams. So these trailers that you see in the picture are mobile units that they drive around the country, and then they will go to certain locations selected beforehand, ask people to participate, and then they do a very comprehensive interview and physical examinations, blood pressure, urinalysis, cholesterol, genetic screening, all kinds of testing. The interview includes demographics, socioeconomic status, dietary questions, all kinds of health-related questions. And of course, they're trying to establish what causes all kinds of diseases. Can we figure out, is this nutrient related to this disease? And so on. It's a very, very large amount of data that they have. Also, this is nice because questions can be added or changed each year. So if there is some new Zika, for instance, you've probably heard about the Zika virus. Well, they can add questions now to reflect something about Zika or mosquito bites, things that change with time, diseases that we're now more concerned about. Things like that can be changed, and then different states can actually have different questions if that's relevant. Alright, this is here because I want to show you an example of a study where they used the data to show prevalence of a disease. So I picked a disease that's very common, unfortunately. It's called diabetes. I'm sure you've all heard of it. How do we know how many people in this country have diabetes? Well, it's from studies like this. This is from the NHANES study. So, National Health and Examination Survey study. I just showed you what that is. And they were looking at prevalence of diabetes in adolescents, age 12 to 19. Okay, now, the NHANES study did not study every 12 to 19-year-old in the United States. So they used statistics to estimate the prevalence based on the prevalence of the disease in the population that they studied. So they did not study 32 million people, but they are estimating based on the prevalence of diabetes in the group that they actually studied. If they, it's called extrapolation. And again, I don't care that you understand exactly how it's done mathematically. I don't even understand how it's done mathematically. But if you study 100 people, you could extrapolate to say, well, if the prevalence is 1% in 100 people, what would the prevalence be like in 1,000,000 people? That's essentially what they're doing. So, all diabetes in the total population of adolescents, age 12 to 19, so again, this is not adults, but in all adolescents is about 0.56%, so about half of 1%. And then you can see this broken down by males and females, and then by race. Non-Hispanic white, non-Hispanic black, Mexican American, other Hispanic, other. And then they differentiate between type 1 diabetes, which is, sometimes it's called juvenile diabetes. This is the diabetes that is more common in children. It's not the one we think of as associated with overweight. This is the one where people tend to inject insulin. Type 2 diabetes is the one that's more common in adults. We'll talk more about diabetes later in the semester. But I just want to show you this is where prevalence estimates come from. All they're doing is they're taking this number divided by this number and getting a percentage. It's simply the number of people that have diabetes currently, not new cases. That's incidence. This is prevalence. So this is how NHANES study is used to estimate the prevalence of diabetes in adolescents. Here is an example of I want to show you the Nurses' Health Study, an example of how this might be used, this data might be used. So this is the title of the paper here that you see, Rotating Night Shifts and Risk of Breast Cancer in Women Participating in the Nurses' Health Study. So what they wanted to do is study whether shift work, working at night, is associated with breast cancer. Something had suggested that maybe people who work at night, women who work at night, have a higher risk of breast cancer. Nursing, of course, hospitals are open 24 hours a day, so nursing involves a lot of shift work. Older women are more likely to develop breast cancer. They've been alive longer, they're more likely to get any type of cancer, typically. And older women are more likely to have worked nights because they've been working longer. If you've worked 30 years, you're more likely to have worked some nights than if you've only been working 3 years because you graduated 3 years ago. So what this means is we have to standardize based on age. So what you see here is, let's see, 78,562 women in the Nurses' Health Study. This column is women who've never worked nights. There's 31,000 of them. Women who've worked nights for 1 to 14 years. Women who have worked nights for 15 to 29 years, and those who have worked nights for more than 30 years. God bless them. You need to standardize based on the age because, again, the women who have worked more than 30 years, they have to, by definition, be more than 30 because they've been working for more than 30 years, and we assume they went to college and all of that. So these women in the far right column are going to be older than the women who have never worked nights. So that there's age standardization. Once again, please don't worry about how to do those calculations. I just want to show you how these types of studies are used. We have all this data from the Nurses' Health Study. I'm really interested in shift work and breast cancer. Well, you have the data to try to answer that question. In this particular case, they standardized by age, which I showed you because we've been talking about standardization. But as you can see, these types of studies can allow you to answer a lot of different questions. Physical activity and heart disease, shift work and breast cancer, and basically any combination of variables you can think of. You can be really creative and ask a lot of really interesting questions with these types of studies. Therefore, many hundreds, sometimes thousands of papers are published using the data from these studies, especially NHANES. It's the largest of these. I hope this has helped to clarify some of your questions. This week you will need to take quiz number 2, which will cover this material. And then you have a post, instead of a discussion, you have what's called Epi in the News. Please read about it in your syllabus, and also make sure you follow the instructions that are posted on the Epi in the News link on Moodle. But it's still a discussion board format, and so it will really function very similar to the discussion last week. If you have any questions, please let us know, and I hope you all have a great week.